Good morning, ladies and gentlemen. First of all, I would like to thank you all for attending this lecture, and I would like to thank IPSA for the kind invitation. Unfortunately, I didn't manage to come personally in Poland, and I hope in the future we will manage to see each other. My name is Nikolaos Polyzos, and I'm the head of the Reproductive Medicine Department in the Nikolaos University Hospital in Barcelona, and I will talk about a crucial part of our IVF process, which is the luteal phase support. We'll talk about new strategies to adapt the luteal phase support for fresh and frozen embryo transfer cycles. And we'll talk about modern things, which is individualizing the way that we supplement our patients with progesterone in the fresh and frozen embryo transfer cycles. These are my conflict of interests. And starting from the scratch, I will highlight the outline, in which I will tell you about the role of progesterone in assisted reproduction. I will talk about the need of progesterone supplementation in IVF and ICSI-stimulated cycles, where there is any difference in the frozen embryo transfer cycles which dominate our clinics at the moment. We go more and more to freeze-all cycles, and we transfer frozen embryos in our clinics. We'll talk about the low progesterone levels before the embryo transfer, the frozen embryo transfer cycles, their impact on pregnancy outcomes, the factors that they affect progesterone levels before embryo transfer, the incidence of low progesterone, and we will finalize with the future, which can be modernizing the way that we treat our patients and going towards an individualized approach, when and how much. So, starting from the scratch, progesterone and assisted reproduction, very well linked together. Why? Because progesterone is important in human reproduction. It leads to the transformation and the receptivity of the endometrium. And we know very well that there is always a balance. There should be a balance between selectivity and receptivity, and progesterone is the form to transform our endometrium so as to let the high quality embryos we create implant. The second part is immunomodulation. Believe it or not, progesterone is not only to mature the endometria of our patients, it has an immunomodulatory effect. And this immunomodulatory effect plays a role in facilitating immune tolerance, in accepting the implantation of the allogenic embryo. Progesterone plays a crucial role there. And finally, so what we have is the myometrial contractility. Uterus is a big muscle. And we know very well, we have seen from studies published, that although the levels of estrogens do not affect the uterine contractility, we see that the higher the progesterone levels, the lower the contractility. And this is very important because a calm uterus that is not contracting can let in a better way the embryo implant. So progesterone is crucial, but when do we need it? We need progesterone supplementation in assisted reproduction. And what's happening in the fresh cycles and the artificial frozen embryo transfer cycles? Fresh cycles, what do? We give injections, we stimulate, we do the oocyte retrieval, and then we supplement progesterone after the oocyte retrieval. Why do we do this? Because we have a luteal phase defect. Our attempt to stimulate our patients has a negative impact on the luteal phase. And if we try to see how big is this impact, we will really understand it by seeing the luteal phase gap. This is what's happening in a normal cycle. This is what's happening in a hyperstimulated cycle or stimulated cycle, I would say. I don't want to use the hyperstimulation word in terms of progesterone concentration. So what do we see? A clear gap. Last days, progesterone levels really drop, and this is happening for several reasons. The luteal phase gap in a stimulated cycle, it's because first, we have supraphysiological estradiol levels. Secondly, because with our oocyte retrieval, we aspirate the granulosal cells from the follicles during oocyte retrieval. And of course, the pituitary suppression in agonist and antagonist cycles result in premature luteolysis. So this means that our luteal phase is not the way that nature has made it. So do we need progesterone? Yes, we need. But what form of progesterone and what route of administration? Because we have cups, we have gel, we have intramuscular injections, which hurt a lot. We have subcutaneous injections, which is the new way of treatment. And we have oral, which of course is at the moment of label in Europe. And we have differences in terms of dosing, multiple versus single doses. We have different blood concentration. We know that the concentration in the blood after vaginal administration is very low, high with the injectable forms and zero with the oral forms. We have a different absorption, conditioned and non-conditioned. We have different side effects, mainly from the intramuscular, and we have different comfort and patient's preference, and of course, approval or no approval. So where are we today? What should we use? And do we have any differences in efficacy? Let's take the fresh stimulated cycles. Have we ever seen what different medications have been used? Yes. There is a meta-analysis published by the Cochrane in 2015, in which clearly shows that whatever medication you use in these patients, either intramuscular versus vaginal or rectal, vaginal versus rectal, or subcutaneous versus vaginal, there is absolutely no difference in terms of pregnancy rates. How can we explain this? It's simple. There are corporal lutea in a stimulated cycle. We have corporal lutea that they produce a little progesterone. So whatever route of administration we use, it's definite that we will have the enough amount of progesterone needed to supplement and support the luteal phase. But fortunately or unfortunately, I think it's fortunate that we are living in a different era. And while 20 years ago, frozen embryo transfer cycles was not something that we used to do, we have opened a great window to the future. If someone sees the worldwide increase in FRED cycles, they will see that until 2012, from 2006 in the States, it has doubled in certain age categories. From 22% went to 41%. And if we see the trend, we will see that while the frozen embryo transfer cycle shows an increase in absolute numbers and reported live birth rates, there is a decrease in fresh live births. We are changing. The FRED cycles are dominating. And why are they dominating? Because first of all, safety. Freeze-all, freeze-all. We're talking about freedom when we were writing this article with Paul de Vries back in 2011, telling that OHSS-free clinic can be the future by segmenting the stimulating cycle and transferring in a subsequent frozen embryo transfer cycle. And today, we are secure that this, what we're doing is the best. Why? Because we have reports published in New England that in high responders, it even results in higher live birth rates to go to a freeze-all cycle. In normal responders, it seems to be the same or even better with freeze-all strategy. And in a study that we participated also and was published in BMJ, we see that the live birth rates in normal cycling women is the same, either you use the fresh or the frozen embryo transfer cycle. Why? Because simply we have advanced in terms of technology. We use vitrification, our incubators are better, our systems are better, and the frozen embryos implant in a beautiful way. The question, however, is whether we need progesterone supplementation in these frozen embryo transfer cycles, and how much. Is it the same with a fresh IVF cycle, or it's different? Because we're talking about luteal phase deficiency and a luteal phase defect, which in a natural cycle can be due to luteal phase deficiency. This has been described, but in an artificial cycle, it's definitely evident and much more evident than anything else because we're talking about the absence of corporal luteum. And we will talk now about the human corpus luteum, which is a beautiful structure. A beautiful structure, why? Because it's actually and transient ovarian gland. Imagine that there is a gland which appears during the cycle after ovulation, and it works beautifully in the luteal phase and the early pregnancy. And what does it do? It produces different hormones: progesterone, estrogen, androgens, growth factors, non-steroid hormones. But actually, what is happening is it's producing a large amount of progesterone, which reaches maximum levels of 40 to 60 nanomole per liter in a natural cycle, and this is enough to sustain and preserve a normal pregnancy. And if we see an early study that had been published in 1970, we will realize what is the actual role of this corpus luteum. In this study, luteectomy has been performed, cutting the corporal lutea or the corpus luteum from ongoing pregnancies through laparoscopy. A very brave decision, but this was the beauty of the study at this moment. After luteectomy, what has been seen is that when the progesterone levels dropped, red line, the patients resulted in an abortion. They lost the pregnancy after luteectomy because the progesterone levels dropped. The corpus luteum was not producing progesterone. When progesterone levels didn't drop, when the luteectomy was occurred in a later phase with evolutive pregnancy, when the placenta has taken over, this means that there was no abortion and the progesterone levels immediately recovered. And this shows actually what is the importance of the corpus luteum. Luteectomy beyond 8 weeks, pregnancy continues. Why? Placenta produces enough amount of progesterone. Before 7 weeks, miscarriage, but before 7 weeks, if there is a luteectomy and there is progesterone administration, the pregnancy continues. This simply shows how important is progesterone in the frozen embryo transfer cycles, especially the artificially prepared frozen embryo transfer cycles. Question: what should we give? Different injection, different capsules, oral, which is off label, of course, and vaginal gel. What is the solution? One study published back in 2018 raised concern about vaginal progesterone use only. Why? Because if you see here, when you compare vaginal only versus intramuscular daily or intramuscular every 3 days plus vaginal, there was a significantly higher miscarriage rate in the vaginal only form, a significantly lower clinical pregnancy rate, but also a significantly lower live birth rates when vaginal only was used. Question: is this the case? Can we rely on this? Of course, there has been a lot of criticism because the vaginal dose was really low. And someone might say that with low vaginal dose, we're under-treating. But definitely, we need to realize that this study by Devinet has shown that the parenteral form, the form by intramuscular or maybe subcutaneous, can lead to different results on our patients. And the question is whether the progesterone levels that we measure for our patients during this supplementation of progesterone may play a role. Why am I telling you this? Because we're talking about different routes of administration: parenteral, injectable, or vaginal. And the big question or the big dilemma that we had in this area is whether it's the same, the progesterone in the serum and the endometrial concentration. Progesterone is important. And there were many people saying that vaginal progesterone is the important part. Of course, we have to see that yes, there is a role of local progesterone because it induces a tolerance at maternal and fetal interface. But on the other hand, there is a big number of other actions that progesterone has and plays, and this can be induced not only by the local administration, by the systemic administration, by an injectable form, inducing the tolerance of the HLA system, cytotoxicity, and of course, inhibiting cytotoxicity and inhibiting T cell activation, playing a crucial role in the periphery as well, through immunomodulation. So the big question that has arisen the last year is whether we really need to measure serum progesterone before a frozen embryo transfer cycle. Because if we're talking about an immunomodulatory effect, it might be completely different administering vaginal progesterone compared to injectable forms in terms of systemic action on immunomodulating action. What is the evidence and where is the evidence? Over the last years, should we measure progesterone levels? Yes or not, ladies and gentlemen? The evidence is there. And if someone looks at the evidence published, as presented in one study, we will see that if we exclude this study, which told us that the low progesterone levels before the transfer had better live birth rates, the vast majority of all the other studies, all the blue ones, has shown that high progesterone levels are associated with higher live birth rates. So why not to go for high? I'm with you. My question is that, look, this babel of different routes and doses, and of course, different levels. This is the major problems of all the studies. Vaginal 2 times per day, 3 times per day. Intramuscular, vaginal various times per day. Vaginal gel, and different cutoffs. More than 20, more than 11, more than 15, more than 11, and at different days of measurement. So we're talking about a big babel of trials with different cutoffs, different levels, different days of administration. So where do we stand? When to measure and how much we need? Because we have this progesterone supplementation, and my question is, should I measure my progesterone levels on the day of embryo transfer, later, or maybe before? Because I need to take an action, and I need to treat my patients so as to manage what? Get the majority of them with an ongoing pregnancy. So is the value the same irrespective of the time or the day we measure it? Or when should we measure it? This is the great question. Let's see what we have. Day of embryo transfer. The day of embryo transfer, the first of the studies, that big study that has been published, was by Elena Labarta, published in 2017, telling us that you need to have a cutoff of 9.2. Why? Because when your progesterone levels the day of the transfer are below 9.2, you have actually a 40% lower chance for a pregnancy. Oh my God, this is not nice. Of course, other studies coming later by Elena showed that this cutoff should be 8.8. So this created even more confusion in 2020, but we realized that around the level of 9 on the day of embryo transfer, when you have lower progesterone, this is not good. What did another group? 9 to 11 days post-embryo transfer. Low progesterone levels at the same level, around 10 nanograms, this is nanomole. This reduces by 50%, again, the chance of ongoing pregnancy rates. But someone might say, why day 9 or 11? I already lost the game. I have low progesterone levels, and this will affect my chances of pregnancy. And what our group has done and published in 2018 is that when you measure progesterone levels, when you transfer euploid, genetically normal embryos, the day before the embryo transfer, although low and high progesterone gives you the same chances of pregnancy, of positive pregnancy test, you have an enormously high miscarriage rate in the low progesterone levels, 26% versus 9.5%, and this affects significantly the live birth rates, leading to lower live birth rates in the women with low progesterone levels. So it's not only the vaginal form of administering, because in the end, we don't know how much is absorbed in these patients. If we have low serum levels the day before, the day of transfer, at a cutoff which is more or less at 10, this might create a problem. But when and how much, if someone says the literature, we will say 9.2, 10, 11 nanogram per ml. Let's go back to school. I still remember in my early years in reproductive medicine that we always wanted to have a progesterone more than 10. I don't know why, or more than 8, 9, 10. This was the threshold. So why don't we utilize a uniform threshold of 10 and say beyond this, we will treat our patients in order to do something individualized. Of course, there is the devil's advocate that tell us, no. How many patients will have low progesterone levels? You don't have to worry. Is it really frequent? Well, apparently it is. If we see all the trials published, we will see that this can range from 34 to 85%. And this is a problem. If I have more than 50% of my patients with low progesterone levels, this 50%, half of my patients will have 50% lower chance for a live-born baby. So I'm harming them. Do I need to measure? Yes, I believe we need to measure. Why? Because there are certain risk factors. Why can a patient have lower progesterone levels? We have published a study in 2020 in Reproductive Biomedicine Online, in which we try to identify the factors that they are associated with low progesterone. In one of the cycles, we have seen that weight, higher weight, lower progesterone levels, apparently has to do with absorption. Sampling time also affected a little, but we're talking about small differences from 12, the mean progesterone in the morning, it was 10.5 in the evening. We're not talking about big differences, but the strongest determinant of low progesterone in one cycle of frozen embryo transfer cycle was a low progesterone in a previous cycle. In a way that we don't know, we don't understand, patients that they don't absorb well vaginal progesterone, they will continue not absorbing it well in the subsequent cycle, with 3 times odds ratio, suggesting to me that these patients need the specific treatment. So what should be the future? Should we stand and wait and do anything? No, I think it's unethical. Should we try to treat the individual patient? Yes. Should we find the patients that they don't absorb? Probably. And try to tailor a treatment based on each patient's profile. Prospective ILPS study in Nikolaos has finished. And this study has been done in women that they were PGTA patients, women that we had euploid embryos to transfer in a subsequent cycle under HRT, artificial cycle with estradiol preparation. Of almost 600 patients, we had quite a good number of patients that they had good levels, more than 10.6 that we found in our previous study. But in 40% of the patients, 40%, which is not at all negligible, we had levels of less than 10.6. And in these patients, what we have seen before in our study, we had 25% miscarriages and significantly lower live birth rates. In these patients, we added subcutaneous progesterone. We added subcutaneous progesterone, 1 injection per day, to correct the progesterone levels in the blood. And what we have seen that the vast majority of them, except of only 4, they had very good normal progesterone levels in their blood and continued the cycle. If we want to see what's happening in terms of live birth rates, this is what we have seen. Equivalent, even slightly better pregnancy rates in the group that had normal values or in the group with low values plus supplementation with subcutaneous progesterone. Ongoing pregnancy rates the same or even better, trying to change the course of what happened before in our previous study, and of course, very low miscarriage rates, suggesting that yes, subcutaneous progesterone should be needed in 40% of our patients, definitely appears to have an immunomodulatory effect, and this can be the solution for the patients that they don't absorb well progesterone. To conclude, progesterone, yes, it is essential in stimulated and in frozen embryo transfer cycles. But we have different routes of administration, which demonstrate similar clinical efficacy in fresh IVF cycles. We have forms that they don't have approval, forms that they have approval, and forms that they are very well tolerated or preferred by the patients. On the other hand, we need to realize that the different routes of administration may demonstrate different efficacy among certain patients in frozen embryo transfer cycles. And this shows that the serum progesterone levels may have an additional immunomodulatory systemic effect, which we overlooked for many years. But we have to take into account progesterone pharmacokinetics, which is different between vaginal and injectable forms. When you inject subcutaneous or intramuscularly, your levels shoot up very high. And this can be the solution for the patients that they are not absorbing well. Accumulating evidence clearly suggests that low progesterone levels have been associated with low live birth rates and high pregnancy losses in the frozen embryo transfer cycles. And this incidence of low progesterone levels is not at all negligible. Half of your patients will have low progesterone levels. What you need to do, adding subcutaneous to vaginal infrared frozen embryo transfer cycles appear to demonstrate excellent pregnancy rates. And this is what we do. Half of your patients will need it. This is what the evidence shows. And if you do it like this, you can save a cycle and you can have excellent pregnancy rates. We have to realize that in 2021, we switched totally from the fresh to the frozen. We are switching a lot. We are having a lot of frozen embryo transfer cycle. If we don't adopt an individualized luteal phase support, taking into consideration the evidence suggesting that the levels of progesterone before embryo transfer are crucial for the miscarriage rates of our patients and for the final live birth rates, then I think we might treat in an incorrect way our patients. And we need to look into the future. The window to the future is look the patient in the eyes, identify the patients that they need progesterone in a different form, in a different way, and treat them the way they should. This individualized luteal phase support is for sure the future of full luteal phase support in our frozen embryo transfer cycle in the future. Thank you so much for your attention.